Continuing the conduction blocks, we talked about the first degree conduction block, and then the second degree that has type 1 and type 2, and then for the third degree, that is complete AV block. So there is a complete occlusion of the signal between the atria and the ventricles. So the P waves and the QRS complexes rhythmically dissociated. The atria and ventricles beat independently of each other, and the atrial rate, of course, is more than the ventricular rate. This could be caused by the Lyme disease, and the treatment should be a pacemaker because it's a complete dissociation. So for the ECG setup, as we can see here, there are multiple P waves that are not necessarily always followed by a QRS complex. So this is P. All of these are P waves. This is the atrial contraction, and we can tell it's more than the ventricular contraction that is represented by the QRS complex over here. This T follows is the repolarization of the ventricles. This is another QRS complex, and then there is a T wave over here. That is the ventricular repolarization. And of course, because we have each P interval, that is the space between each P and the next P, between each atrial contraction and the other atrial contraction, it's the same time, the same length. So we should be having here a hidden P wave. So these are similar to each other. So we do have under this QRS complex a hidden somehow P wave on the QRS complex. So and of course, as we said, that the QRS complexes are less than the P waves because the ventricular contraction is less in the rate than the atrial contraction. So that is the complete atrioventricular block. And then we have the bundle branch block. Okay, let me see. Yes. So this is an image of the heart. What is happening here? Let's read. It's an interruption of the conduction of normal left or right bundle branches. The affected ventricles depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle, which depolarizes via the faster His-Purkinje system, sorry, and then commonly due to ischemic, that is the MI, or degenerative, like the cardiomyopathy, inflammatory disease. Um, so what is happening here? We know that this is the SA node and this is the AV node, and now they have the bundle of His over here. For these two parts, this is the first one, that is the left bundle branch block, and then this is the right bundle branch block. So let's suppose we have a blockage somewhere here in the left bundle branch block. So what is happening is that the left ventricle now is repolarizing, not depolarizing actually, not through the normal left bundle branch bundle branch, because we have a blockage over here now. So it's not, this is not working. What is working is just the normal myocytes. These myocytes, like the whole thing is made up of myocytes, so they get the contraction from the normal ventricle, that is the right ventricle. So it has its own myocytes that are depolarizing, so they somehow transmit this depolarization to the left ventricle. But of course, because this depolarization is going through the myocytes, then it's much slower. So the left ventricle depolarizes slower than the right ventricle, because the right ventricle is getting its own depolarization through the normal pathway. The normal pathway is the right bundle branch that is not blocked, so it's just get it through the bundle of His, so it's normal, and it's fast. While in the left ventricle, because we said that we have blockage over here, so the only way of transmission is through myocyte to myocyte, so it depolarizes much slower. And this is the bundle branch block. It could happen in ischemic changes or in degenerative changes, like or infiltrative changes as well. For the premature beats, we have the premature atrial contraction and the premature ventricular contraction. So basically, what is happening is uh, a contraction that precedes its expected time. So it's not mature enough. Um, for the premature atrial contraction, it says that we have extra beats arising from ectopic foci in the atria instead of the SA node, often secondary to increased adrenergic drive, like in caffeine consumption. It is benign, but may increase the risk for atrial fibrillation and flutter. The new narrow QRS complexes with preceding P waves on ECG. So if you if we take a look at the same image over here, so we already said that the source of the depolarization is from the SA node and it is in the right atrium. So what is happening here is that there is this purple foci in both the ventricles that they do depolarize on their own, and that's how they transmit the signal. So this is called a premature atrial contraction because these ectopic foci do have somehow similar capability of the SA node to induce an actual contraction in the atria. So this happens because it could be happen secondary to increased adrenergic drive, like in caffeine, as we said, and it is benign, but it may increase the susceptibility to have atrial fibrillation and flutter, because we know that atrial fibrillation and flutter they both happen in the atria. So the QRS complex with preceding it is a neuro QRS complex with preceding P wave. So this is an ectopic. So if we can take a look at the whole thing, this seems normal, and this as well seems normal. That is the P wave coming from the atrial contraction of initiated by the SI node, while over here this P wave is the ectopic one that happened because of the atrial contraction due to the ectopic foci. So it is followed by, then it's followed by a narrow QRS complex over here. So this is the one that we're talking about, and this is the second one that we're talking about. It is a benign because it's fine. We're not having any block or anything, but so it's fine. But I mean, it increases this ability to AF and atrial flutter. For the premature ventricular contraction, we have ectopic beats arising from ventricles instead of the SA node. So now the what we're having is the ectopic foci themselves are not coming from the atria; they do come from the ventricles, and they do their own polarization depolarization thing. So ectopic beats arising from ventricles instead of the SA node, they have shortened diastolic filling time, so there is reduced stroke volume compared to a normal beat. The prognosis is largely influenced by the underlying heart disease, about like what is causing this condition to happen. We see wide QRS complex with no preceding P wave because it started in the ventricle itself. So what is happening is because we do have now an ectopic piece in the ventricle, so the ventricle is depolarizing on its own. So because it's depolarizing on its own, so it doesn't follow the actual normal kind of slow rhythm of the SA node. So it beats faster than expected because now it's getting impulses from the SA node first. That's one, and then now let's say we have one here ectopic foci, then it's getting another um, um, conduction or another order from this ectopic foci over here. So it beats due to two sources, due to one and due to two. That's why it beats faster, and if it beats faster that means it's contracting faster. So this is the contraction phase. If it contracts faster, then it doesn't have enough time to be filled during diastole. So it doesn't have enough time for the blood to flow from the atrium into it because it's already contracting too much. So it doesn't have enough space to allow that filling. And of course, on the ECG, we see a QRS complex like this one doesn't necessarily preceded by P wave because it's due to the ectopic foci, and ectopic foci is beating on its own, so there is no induction due to the SI node. So what is happening here? This P wave is normal. This is due to the SI node, and this QRS is also um, the contraction of the ventricle due to this SI node from the atria, and this is the T wave, that is the repolarization of the ventricles. But this whole QRS thing is just the ectopic beat of the ventricle. And we have, of course, here this normal contraction. This is the other normal contraction. Well, and that should be it. This is, of course, largely influenced by the main outcome depends on what is causing these ectopic foci to be there, like what is the underlying condition. Now for the hereditary channelopathies, so these are the channelopathies related to the ion channels that are responsible for the depolarization or repolarization of the cardiac muscle. So for one, we have the Brugada syndrome. It is an autosomal dominant disease because it's hereditary, so there should be some inheritance into it. So autosomal dominant disease most commonly due to loss of function mutation. So there is a mutation, genetic mutation, that is causing a loss of function in one of those channels, and that is the sodium channel. And we know that we need the sodium channel to initiate the differization of the myocyte. So what is happening? There is a pseudo right bundle branch block. So it's not real bundle branch block. It's a pseudo. There is on ECG, there is an ST segment elevation in lead V1 and lead V2. That's on ECG. The treatment, we need to prevent sudden cardiac death when with intracardiac device. If we take a look at the contraction actually of the heart, it should be here somewhere. There you go. So this is the contraction of the myocyte. It's a little bit messy. Okay, so for phase 0, we need the sodium channel to allow for the influx of the sodium into the myocyte to start the depolarization thing. And then we also have a need for the repolarization to use the potassium channels. That is will allowing somehow the efflux of the potassium channel to keep on, for the muscle to keep on repolarizing. So if we do have a problem with these channels, that means we have, as a result, a whole problem with the contraction of or repolarization of the cardiac muscle. So if you go back, it should be here somewhere. Yeah. So that is for Brugada syndrome. If we take a look at this image, this is how the ST elevation looks like. It's already too high. Okay, and as we said, that the problem is in the sodium channel, and yeah. So for the congenital long QT syndrome, it is caused by mutation of the KCNQ1. This mutation leads to loss of function as well, but this time in the potassium channel, and that is affected, and that affects the repolarization of the muscle. So there are two subtypes. The first one is Romano-Ward syndrome. It is a autosomal dominant. This is the mode of inheritance. It's a pure cardiac phenotype, so it's basically the whole thing is only affecting the cardiac muscle, so it's just pure cardiac phenotype. There is no deafness. While Jervell and Lang-Nielsen syndrome, I'm not sure what's called, but anyway, is autosomal recessive. This time it's recessive, but it also has a sensory neural deafness. So now we have, in addition to that, is the sensory neural deafness. Okay. So the sixth sinus syndrome is an age-related degeneration of the SA node, so it depends on how old the person is. ECG can show bradycardia, sinus pause, sinus arrest, and junctional escape beat. So I guess it says, as the name implies, is just the SA node is not functioning as it used to or as it should be functioning because this person is getting older. So there is bradycardia, sinus pause, sinus arrest, and junctional escape beat, and this is the ECG rhythm. That's it.